Welcome everybody. For those of you who don't know me, my name's Claire Austin. I'm one of the Pro-Vice Chancellors here at Edge Hill and also Dean of the Faculty of Social Care and Medicine. Sorry, I had a mental blank then. So I'd like to welcome you all to Edge Hill, whether you're here in person or online, to hear from and to celebrate the achievements of Professor Greg Irving, and thank you all for joining us. We do really appreciate that. So it really is a great privilege to introduce Greg to you tonight. Greg's an academic general practitioner. So he completed his medical training in Nottingham before going on to postgraduate studies in Oxford and Liverpool. He's got a very impressive CV. He studied at Harvard University as a global clinical scholar and worked as a clinical lecturer in Cambridge. And from Cambridge he came to Edge Hill to join our new medical school, and he played a really key role in the development of our undergraduate medicine programme. He was subsequently appointed to the role of Director of our Health Research Institute, where he's really done a fantastic job leading the development of significant interdisciplinary research, both within the university and external to it. And he's also led the establishment of the Edge Hill Centre for Primary and Integrated Care, or EPIC, because it is. So Greg's personal research achievements are significant. He's received 3 consecutive personal NIHR fellowships. He secured external grant funding of over 9 million, and this includes a recent Mental Health Leaders Award, a £2.5 million award, which is one of the biggest that Edge Hill has received. He's consistently featured in the Stanford World Top 1% of scientists in his field. He's published extensively, and his work has contributed to over 70 policy reports on primary care across 30 organisations, including the World Health Organization and the National Institute for Health and Care Excellence. He holds numerous external roles, including the National Specialty Lead for General Practice in the NIHR Research Delivery Network. He's a nationally elected member of the Society of Academic Primary Care Executive Committee, and locally he's the Associate Medical Director for Research in the Cheshire and Mersey ICB. He's a past recipient of the highly prestigious Yvonne Carter Award for Primary Care Research. And that's why I had to write all those things down, because that's only a flavour of some of the achievements. Whilst Greg has achieved a great deal, I know that personal recognition isn't what drives him. He wants to make a difference. He grew up in St Helens, he lives in St Helens, and now works as a GP in St Helens in a very research-active practice. I know he's acutely aware of the health and care challenges of the region, and much of the work is focused on improving care, outcomes, and reducing health inequalities for research. And this absolutely aligns with the focus of the medical school here at Edge Hill on supporting young people from less advantaged backgrounds to enter careers in medicine. Greg's a fantastic colleague. He's collaborative, a great team player. He works incredibly hard. I think there's more than 24 hours in his day, and he's always happy to help. He's a great networker, seems to know everyone, but he's so well liked and respected by all who know him. It's my great privilege to invite Greg to deliver his inaugural lecture, Health's Hydra, Confronting the Challenge of Multimorbidity in the NHS and Beyond. Greg.
Thank you, Claire. That's a very kind introduction. Thank you very much. So tonight's talk, I'm going to focus on multiple long-term conditions, which I'm going to pose as probably one of the greatest challenges to our population of our time. And I've termed it Tackling Health's Hydra because I think that, so if we look back into Greek or Roman mythology, so the Hydra was very much a symbol of complexity. It was was a challenge by so Hercules, who or in Roman culture, or if you look at it from a Greek perspective, with his 12 labours, Hercules essentially was set 12 labours. The second one was to tackle the Hydra. The Hydra, as I said, it was seen as a symbol of complexity. It was a multi-headed beast, and because of its very nature, it very much symbolised a way of requiring teamwork and strategy to overcome it. So that's why I've chosen it as the theme for this evening. I started out life, I was born in St Helens in Western Hospital. My mum and dad are here, Anne and Godfrey. I've been served well by the town over time. I was educated in the town. I did a big part of my medical training put in a postgraduate setting in the town. And then I had the privilege of actually working there in the clinic. So this is inside the surgery where I work in Marshall's Cross. So Marshall's Cross, it sits within the what is now the Merseyside and West Lancashire Trust. So it was previously the St Helens Hospital. I came to work there, and I just wanted to introduce you to someone who was, I guess, a key mentor in my career, and that's John Holden. John was a local GP who actually helped to establish the practice. John was, I would say that he was a typical clinical scholar in the very true sense of the word. He had an output that would rival many full-time academics in terms of his writing and outputs. But John very much steered me onto a path of engaging and seeing the real intrigue from a clinical academic position. So John was quite a character, and he had this thing called what he called a grand tour, where he identified key people in the world of the academic general practice, primary care, that he said you must meet and go and have a conversation with these people. Sadly, so this picture was taken in at the foot of Tryfan. So John, we used to often go walking in the mountains together and discuss all kinds of things, but John sadly died after this picture was taken. He was in a fell running accident in the Lake District, but he's very much been a strong influence on my clinical academic career, and I think it's fitting that we begin the story with a bit of a tribute to John. So on John's tour, one of the people that he encouraged me to meet was Julian Tudor-Hart. I was doing a clinical academic training pathway at the time, and I'm really delighted that Edgehill's now got a well-established clinical academic training programme that can help others experience this. I was rated one of the first cohorts that went through one of those training schemes, and I really benefited from it. And it gave me the opportunity to meet people like John and have some space for engaging. So on John's grand tour, and I did have to dig out some old photographs. He took me to Glencorweg in the south, in the valleys in Wales. And those of you who you might not, some of you will know who Julian Tudor-Hart is. Others might not. He developed a thing called the inverse care law, where he argued that the availability of good medical care tends to vary inversely with the need for the population that it serves. And that operates more completely where medical care is exposed to market forces and less so where exposure is reduced. So he's a passionate advocate for the NHS, and a lot of the work and understanding we have around inequalities comes from the original work of Tudor-Hart. John wanted to go to Glencorweg because there was some clear parallels. There was a practice there where they'd done practice-based research, engaged with the local community, and by offering universal access and really good coverage, Julian had managed to objectively demonstrate the benefits of really high-quality primary care and engaging with the population. He was quite elderly and frail when I met him, but he really sprung to life when we were there. And one of the conversations that we had was around he recommended I read a book by a gentleman called Alvin Feinstein. I had never heard of Alvin Feinstein at the time, but Alvin Feinstein was a very eminent clinical epidemiologist in the United States, and he was very passionate and meticulous about clinical epidemiology and how we describe disease. He coined the term comorbidity, which I think many of you will be familiar with now, and he came up with many other neologisms or made-up words to kind of describe some of the epidemiology. I was fascinated to go back to the old text, to what was then becoming an older text, just to see some of the early thoughts that he had around that, the sequence of disease and how that influences outcomes, but also the impact of deprivation and other factors on combinations of disease as well. And Feinstein, one of the quotes that I liked was that he said that the patient with multiple diseases is not simply the sum of his diseases. So at his heart, he was a true clinician, very patient-centred. He was a fine epidemiologist. As part of my academic clinical fellowship, I had the chance to go and work in Cambridge. I was working in the MRC epidemiology unit, and I worked under Professor Simon Griffin on the edge of the screen there. Simon, I would say, is one of the finest clinical epidemiologists I've ever come across. He's very modest, but his attention to detail and understanding of methods and approaches was second to none. So I really did benefit from that knowledge. Simon replicated some early work. So there was some very good work by Stuart Mercer et al. And the team in Glasgow looking at the sequence and basic epidemiology of multiple long-term conditions in the Scottish population. And Simon did some very similar work in England as well, using this the clinical practice research data link. So it was one of the very early stages of describing the epidemiology. I had the chance to refine some knowledge and understanding around clinical epidemiology in Harvard. What I was doing, it was linked to the clinical lectureship I had, and I think just highlights one of the benefits of the training programs and the funding that comes, and it does create, the NIHR program does create some really good opportunities for you that you just never would have had the chance to experience otherwise. So there was this young boy from St Helens having a chance to go and work with some of the world's best again, clinical epidemiologists, and it really was an eye-opener. They would, in their phrase, they would teach you to turn the soil and how to look through the data. Some of them would analyse data as though they were playing an organ or a piano, with their skills of handling the data. It was really something to behold. So it was a great opportunity for me. So this is where I was brought up and where I work in St Helens. It's a map and it shows the levels of deprivation. The darker red areas are the more deprived areas, and the lighter shaded areas are the more affluent areas. So I was brought up in Eccleston, a relatively slightly more affluent area on the edge of what is quite some deprived population areas. And I now work very close to where the town centre is, right in the heart of where that deprivation sits. So that was quite important for me in terms of thinking about building networks with other practices of where they were sharing similar challenges, working in those populations where there is quite marked deprivation brings some challenges, and it's really good to have that community of practice and share knowledge. So we actually brought the team from Glasgow down to Liverpool, and this was David Blaine, who's one of the leaders in the Scottish Deep End group in Glasgow, who came to share some of the experience of setting up a Deep End group, and we established a Cheshire and Mersey group of our own. One of the first things we did was we replicated some of the epidemiology that we discussed before about the population that we were looking after in St Helens, and how did it compare with other settings. And there's many ways to look at multiple long-term conditions, but I'm going to argue that this is today's Hydra. So this is the multi-headed beast, if you like. It needs teamwork and strategizing to overcome. It's particularly complicated in that you can't just simply eliminate conditions. They are, they're deeply embedded, and it's part of the institution of medicine and wider health economy that kind of drives some of this as well. But just some quick highlights on the graph. I don't want to go into too much detail, but along the bottom is age, and up the side is proportion of patients. And where the grey line is when you hit one condition. Where the green line is where you hit multiple long-term conditions, 2 or more. So what we were seeing in the St Helens population, we were seeing a shift to the left. So we were seeing replicating the same methods, similar approaches to analysing the data, but we were seeing the population accumulating disease in young populations, children, young people, driven largely by mental health and obesity. And we're also seeing the onset of, so we've drawn a line around when 50% of your population has multiple long-term conditions. That was shifted almost a decade earlier than in some of the other studies. So there's some real challenges there. What's driving it? Why has that happened? And yes, some challenges might be methodological, how you've measured the data, the different types of data set. But I think above and beyond that, there's a real problem. And that is that there's a true element of people accumulating more and more conditions. This is a figure put together by part of our team here at Edgehill, and particularly led by Anna Evans, one of the our NIHR ARC funded PhD students. And we used the similar data set to look at the number of consultations that are happening. And there's a lot in the media at the moment about can't get in to see my GP, and the pendulum swinging between remote consultations and face-to-face. Well, this is for that population we've just seen. This is just looking at the number of consultations. And you can see when we hit 2020 along the bottom, there's a big drop-off in face-to-face and a lot more remote green consultations introduced. But the pendulum has not stopped swinging yet. The number of face-to-face has actually gone up to pre-pandemic levels, but all those virtual consultations as well have remained there as well. So people are working extremely hard, but you're still hearing the in patient reports about difficulty with access. So there must be something going on. We're also seeing people with, and Anna's done some fantastic work around this, looking at people who don't have mobile phones or digital access, having some demonstrable challenges in terms of getting in. So the rates of accessing services are becoming a challenge. So again, it's having that Tudor heart lens and looking back at the problem is a real issue. And this is perhaps part of the problem. So this is a figure looking at the number of doctors per capita in Cheshire and Mersey. So we're not talking about a really big population. It's about 2.7 million people in total. But if you look across the population, have a look at the number of whole-time equivalent doctors. If you start over here in central Liverpool and Wirral, you've got 0.8. But take a look at Knowsley. 0.5, St Helens is not much better. So the number of doctors per capita within the same ICB region is significantly different. And that's really impacting on access and really driving. So it's almost like a very definite definition of some inequalities at play. And there are there's a wide body of evidence there, the number of doctors per capita that you have, number of family doctors or GPs per capita that you have is really important for a whole host of reasons. And there's 20 plus mechanisms of how it can improve mortality and things like that. So this is, if I was a member of the public, that's the thing I would be saying I'm upset about rather than access per se. So what's driving some of this? I think certainly deprivation is a key one. If you look at Cheshire and Mersey, you can see these are all the ICBs ranked by levels of deprivation. And if you look at the red sections, that's the amount of deprivation that within the population for each ICB. Cheshire and Mersey, similar with Greater Manchester, they're right down at the bottom. So the northwest is really hit quite hard from that perspective. And I think there's similar challenges across within the ICBs as well. So whilst there is some significant pocket deprivation in places like Wirral, it's generally a little bit more affluent than places like Knowsley as well. So you really see that writ large in that sense. Next is a figure, again, same data set, same population, looking at the proportion of people who have multiple conditions, so 2 or more conditions. So for example, if you pick by the age of 40, these segments are split by levels of deprivation, so whether you're living in an affluent area or a less affluent area. And by the time you hit to 40, there's almost a 15% difference about the levels of multiple morbidity in the St Helens population. So if you lived in Eccleston, for example, compared to someone who lived in Parr or the central area where it's more deprived, you're going to find a much more significant burden of disease. And that's quite, that gap is quite shocking. That is a real example of inequality. I won't go into too much detail about this, but we've mapped the combinations of diseases that sit together. For example, one of the common conditions that you see together is high blood pressure, hypertension, and kidney problems, and that's a really common combination. And if I was looking at the health economics of it, if I was a commissioner, that is one that I would really target because it gives a big bang for your buck in terms of the number of people who've got those combination of diseases. And from a health economic point of view, that would be a really beneficial thing to do. But you very seldom see services designed around those multiple conditions. It's often know your numbers for hypertension or no mention at all about other chronic kidney disease. So maybe there's some missed opportunities there. And that's driving lots of other problems. So one example is polypharmacy. So this is a figure looking at the number of conditions and then the number of drugs that people have. And there's almost a linear relationship between the two. In the data sets we were looking at, there's people on combinations of 30 plus drugs. As I said, that really can't be healthy. I put a picture in here of a piece of artwork called Armour that sits in the RCGP by an artist called Susie Freeman. So Susie's in the top window up there. So if you ever go to Euston Station and cross the road, the RCGP is literally over the road from Euston Station in London. And there's a fantastic piece of work. And Armour is made out of the pill packets of a gentleman in his last 5 years of life. It's a ginormous piece of work, but it really hits home about the magnitude of the problem. There's lots of other pieces in there. There's dresses and all sorts of people taking contraceptive. But Armour particularly is, I think, a very pertinent way of... art can sometimes speak louder than figures, and I think that's a really nice way of doing that. Risk of death. So this is a figure looking at the risk of death within 1 year if you have multiple long-term conditions. We know that multiple long-term conditions is associated with premature mortality. It's associated with all-cause mortality, lots of different measures of death. But there really is a strong relationship between risk of death in the next year. So it's really something to take importantly from that perspective. And is this a phenomenon that's just happening in the UK or in the Western world? No, it's a global phenomenon. So we're seeing similar patterns of multiple long-term conditions in many countries. So it really is a global challenge and not just something parochial and specific to the community. Okay, so I've mentioned about the Hydra and how it symbolises complexity. It's a difficult labour to overcome, if you like. And when Hercules, or for the Greeks, Heracles, I was the word I was trying to think before, when he initially approached the Hydra, he attempted to chop the heads off one by one. So brute force, chop a head off at a time. but very quickly he realised that the head would return, grow back, and often two heads would grow back rather than just one. And I think we see similar phenomena with attempts to tackle multiple conditions as well. So this was this is a very old article that was in the BMJ in 1998 by Arthur Hibble, who was one of my mentors down in Cambridge. And Arthur wrote a piece called The Tower of Babel that was about the number of guidelines that are being produced into practice. He measured it, weighed it, and it was a phenomenal amount of, as you can see from the image, amount of guidance. This is pre-digital guidance and pre-NICE. There are now 250 specific guidelines that are produced by NICE, and I do think I used to do a lot of work with NICE. I think NICE are a very well developed organisation, and they really do some excellent work. But there's 250 disease-specific guidelines. There is one on multiple long-term conditions, and it was written over 10 years ago and hasn't been updated since. I think we're really missing a trick in terms of how we're operationalising, tackling some of these challenges. And I'm going to turn to some patient narratives now, if that's okay, because I think it really adds some flavour where, so you can hear from the patients themselves. I feel like I'm spending more time managing my health than living my life. Every week, there's a different appointment, a different specialist, and no one joins the dots. It's like having a full-time job with no pay, organising my medications, appointments, blood tests, and repeating myself. And these are from different studies and different reports. It's the same messages about the burden that this puts onto individuals as well. So I would argue it's not truly patient-centred. And I think it's to do with how guidelines are developed, the stakeholders that are involved, and how they're produced. And that was very much what I did in my PhD. I looked at the processes of how guidelines are developed. I looked at heart failure. And for example, there was very little about deprescribing, very little about what happens when you approach the end of life, and non-drug interventions as well. So there's quite a few things to consider in how guidelines are developed. We've mentioned a little bit about this before, about the number of drugs. So there's a rising tide of polypharmacy. We know it's a big challenge. And when I'm in the ICB, I hear people talking about drug bills all the time and how can we reduce it. We've seen this is an excellent one of the early epidemiological studies by Bruce Guthrie, and again a team in Scotland looking at the rates of polypharmacy, and they compared 1995 to 2010, and so it's going back a reasonable amount of time, and you can see there that there's that rising tide of polypharmacy was happening then, and it's got even worse since then. People should be angry about some of this in terms of like the impact that it has, and I would say that it's contributing to inequalities a number of years lived in good health versus poorer health. So this is national level data now, looking at the most deprived communities. They're spending about 51 years in good health and 26 in poor health, compared to the least deprived that are having 70 years in good health and 15 in poor health. So it's not about eliminating all disease, it's about using health as a resource for living and giving people the opportunity to have maximised those years in good health. So turning to science and research, there's been some really excellent work that's been produced to try and tackle multiple long-term conditions. And one of the key studies was this one by Chris Salisbury, and very much a leading expert in development of interventions for multiple long-term conditions. It was called a 3D study. It was an incredibly well-designed study. They did all the right kinds of things involving stakeholders, patients, co-designing it, thinking about inclusion and using theoretically driven models for developing their interventions. But it yielded a negative or a non-significant outcome, which was quality of life was their primary outcome. And when I read it, I was initially a little bit disappointed. I was hoping it was going to be a bit of a guardian light about how to approach and how we should adapt care. They did lots of really nice things like looking at reducing the number of drugs, longer time with patients and things like that. But it's really interesting as to why it yielded a negative result. And I have my own views on it, and I'll come to that in a minute. We've seen similar studies as well replicated in different countries, perhaps not to the same size as the 3D study, but I think they're an important reminder that there's still a lot of work to be done in this area in terms of trying to find interventions that are effective. And I think fundamentally part of it is about the complexity of the underlying problem that we're dealing with and trying to develop it. I'm going to turn to Ivan Illich now. So those that you don't know who Ivan Illich is, he was a Roman Catholic priest turned philosopher who wrote quite extensively about counterproductivity in lots of different institutions, transport, education, and also health. And I think I came across him when I was doing some of my master's studies. It felt pretty radical at the time, and I was like, oh, it's very critical of the health system. But one of the things he described was iatrogenesis and medically induced harm. But I think he really hit on something with describing that counterproductivity that can occur in healthcare sometimes. So although like guidelines and other interventions are very well intended and they sound robust and sensible, there's an element sometimes in how we do things that they can be counterproductive. Illich also had some other lessons that we'll come to as well about, so he described a medical nemesis, which was, he described the nemesis as a beast, that when you try and overcome one era, you unlock another era. So he said the era of infection, science overcomes it, and then we turn to the area of chronic disease, and then you overcome the area of chronic disease, and it might be neurodegenerative disease, and you always unlock a different era. And I think Illich is in the back of my mind when I'm thinking about multiple long-term conditions, and we mustn't have any hubris or overthink that we can like eradicate multiple long-term conditions. I think those conditions to some degree are here to stay, but it's how we get the balance right and avoid that counterproductivity that can occur. So Hercules, or as we said, he took a different approach. So he worked with his nephew, and they came up with a strategy about how they were going to beat the Hydra. And it's an important message of teamwork and strategy. And I think that's key to tonight's talk about how do we do things differently. So he used fire. So when he cut the head, they cauterized the head of the Hydra, and they worked together to tackle the problem in a very different way, a very different outlook, and teamwork was absolutely a key to that. As I said, one of the heads was the immortal head as well. So they used a different strategy for that as well. So they used the rock for covering that head. Hence the Ivan Illich point I made before about just having a little bit of, being mindful that nature is very powerful, and you can't stop people having problems and having disease. You can go somewhere to trying to prevent things and giving people good, maximising the years of healthy life. But to eliminate things altogether, you need to have an element of caution. So I'm going to turn to Chris Whitty next. So everyone knows who Chris Whitty is now. So Chris wrote this very nice editorial about rising to the challenge of multimorbidity, about needing different approaches, and I completely agree with him. It needs to be done differently. He argued that good vertical integration exists from bench to bedside for single condition diseases, but there's little or no horizontal integration between diseases that often coexist. So require an intellectual shift and rethinking some elements of our research training in practice. And I like the last line, in virtually every discipline. I don't think it's just my responsibility for dealing with this. I would challenge the entire scientific community to think about it. It's not just, it's got to be in all aspects of work that's done. I think that's a really key message today. So in virtually every discipline. So we all need to it's everyone's challenge. And the NHR have really done a lot of excellent work around coming up with a strategic framework for long-term conditions. So some of the challenges they've said, can we look at mapping common clusters and how they develop over time? Identify what matters most to patients and carers, so that inclusion piece, patient and public involvement is really, really important. It's sometimes been lacking in some of the studies previously. Looking at patient-centred care models that improve quality of life. How do we prevent long-term conditions? Addressing health inequalities in underserved communities and improving research methods and multiple conditions. So that's a big challenge for the entire community. I'm going to focus a little bit on what some of the bits that Edge Hill have been doing recently and the team in EPIC. So there's this new cross-NHR collaboration that's launched to tackle multiple long-term conditions. So every part of the NHR is being focused on the challenge. So I think that chimes very nicely with the it's everyone's responsibility. And we've based a lot of what we've done at Edge Hill on the literature. So these are patient-reported points around and questions that have been co-designed by patients, staff, NHS staff, researchers, the entire community, and kind of prioritised. So and this is looking at it very much from a primary care perspective. So we've picked a few within EPIC that we think are really important. So I should say that work was done by the School for Primary Care Research, which was a really valuable contribution. So the ones we've looked at is how can we improve quality of data that we gather from primary care, better understanding of multiple long-term conditions, and we've mapped some of the awards that we've had to that. How can primary care interventions contribute to prevention of disease, onset and decline, and function or quality of life? So that's looking at models of care, and how can we better interact with wider health and social care systems to improve multiple long-term conditions. So again, looking at models of care. We've also tried to tackle that bigger challenge about clustering, and we had some funding from the ARC to look at that as well. I'll come to that in a minute. So we've been awarded one of the NHR Team Science Awards, which is a very methodological piece, and it's the award specifically focusing on the multiple long-term conditions call. And it's been a really illuminating thing to do, to really embrace interdisciplinary research. So it's a complex problem, multiple long-term conditions, and it's really bearing down on that complex problem with that interdisciplinary expertise, looking at things from very different perspectives: computer science, psychology, social care, patient and public experts, like the whole lot. And divergent thinking is encouraged within it, and there's lots of really robust underlying thought given to how teams are developed in scientific communities. That, for me, that's been a real eye-opener. I've been working with teams in Durham, Oxford, Manchester, across the country, and it's been really great to do that. Another piece we've done that's been with the funded by the North West Coast Applied Research Collaboration is looking at that clustering challenge. So how are clusters formed? And we went back to about the Alvin Feinstein slide that we showed about looking at the sequence of conditions. How do they occur over time? So we've tried to look at that. So this has been done by Lucy Kaluvu, who's one of the PhD students, and Anna Evans as well. So they're both excellent up and coming rising stars in the community, and a real asset to Edge Hill. Lucy was just nominated for a North West Coast Innovation Prize for some of this work that she did. So we managed to map the top 10 long-term conditions, and perhaps no surprise, hypertension, diabetes were up there. So this is using the Cheshire and Mersey data set, so it's very local data. We were able to look at the sequence in which people get those long-term conditions, and this is really getting into the areas of new knowledge, of looking at how these clusters start to evolve. So we can see hypertension's often the first condition, hypertension's often the second condition, and it ranks highly in the third as well, so it's definitely one not to miss. You can see the other big hitters like diabetes coming early on, You can see, some musculoskeletal problems. Cancers and things like that are, these are really important condition areas, but they tend not to come early at the first in the cluster. So by the time people get cancer, they've often got an accumulation of these other chronic conditions. So we managed to do some fancy statistical analysis that grouped those conditions together. It's called latent class analysis. And we were able to look at how they all group together as a pattern. So we came up with these 5 groups: heart disease and chronic kidney disease, cardiometabolic, hypertension and mental health and other cardiovascular disorders, and musculoskeletal problems. They were named after what was the most dominant diseases in the clusters, but we could have named them other ways as well. I should say this work was co-designed with patients and local GPs as well to make sure it was of use. And we looked at how the distribution of those conditions sits within those clusters. So this is like basic epidemiology, just trying to unpack how diseases are grouped together, how are they forming, how are they occurring together. And also, like, what was the age distributions, what are the characteristics of it? So we can see here, I won't go through them all, but like the mental health and cardiovascular disorders cluster coming in younger people, through to musculoskeletal that was occurring later down the line as a cluster. That was really important to kind of get an idea of, if you were developing care pathways, this kind of knowledge is really important. We were able to look at the distribution of deprivation within the clusters as well. So what was the social epidemiology of that? And we can see that some of the clusters are really, look at the mental health and cardiovascular disorder one occurring, a big burden happening in those quite deprived communities. I'll just show you one of these figures for an example, but we were able to look at outcomes and how people with these conditions interact with the health service and different parts of the health service and social care as well. So in terms of unplanned admissions, so we used the hypertension and chronic kidney disease as a kind of baseline marker to compare all the others to. And you could see things like mental health and cardiovascular disorders having a much higher rate of unplanned hospital admission. Musculoskeletal, not much different. Cardiometabolic disorders, different. A significant proportion of unplanned admissions in that group. And similar with cardiovascular other kidney disease as well. We looked at it for inpatient hospital days. So this Edgehill does quite a lot of work with the musculoskeletal teams at Wigan and Wrightington, one of the key partners, and they do a lot of excellent musculoskeletal work. And this is like an important point for that team maybe, that once the musculoskeletal cluster gets into hospital, they spend a long time in there compared to some of the other clusters as well. So all the more important for thinking about how your care pathways are developed. A&E, so we see A&E is a hot topic, isn't it? You see in social media it's really busy. Is there anything you can do? Can you go elsewhere? Well, you can see how the clusters respond to that as well. Most of the other clusters, you can see that they have quite a significant proportion of A&E attendances. And this was also a really important piece. We were able to map social care utilisation. So a lot of studies that you see looking at multiple long-term conditions, they might just look at the NHS-based outcomes, A&E, unplanned admissions. But the data set we had was really unique and it had social care flags within it as well. And we could see which of the clusters were ending up with having a significant amount of social care utilisation as well. So things like the cardiometabolic disorders, we're getting slightly less, slightly more social care interventions. And the Tudor Heart inverse care law as well that we mentioned before, we could see that writ large in social care as well. So it's not a phenomenon that just happens in healthcare. It was happening in the wider care setting as well. And it was fascinating to see where referrals were coming from. I expected it to be patients, carers, maybe the GP, but no, it was that plus police force and other agencies as well. So there's some really complex disentanglement to do there about how health and social care interacts and for long-term conditions. So it's really quite novel, having that integrated social care, and I think it really lends itself to that big data picture. I think a next step would be to look at using machine learning approaches for some of this clustering work, bigger data sets. It's very computationally intensive what we've been doing, and it would be really fascinating to look at the performance of some machine learning approaches compare it to some of the more classical statistical techniques we've done. So thinking about that kind of prevention and upstream work, one of the big pieces of projects we've had funded recently has been the Mental Health Leadership Award. This is a really significant award, and it's very upstream, focusing on children and young people. And there's a lot of excellent work that goes on in the university as a research ecosystem that looks at that population and health through Professor Vicky Karku's work for Arts for Us. There's excellent work with Everton in the community. A lot of this focuses on important conditions like mental health conditions, but quite often overlaps with physical conditions as well. So it's really starting to dip into those upstream areas for thinking about prevention. The research project focuses on community assets, and I think that is a really important piece of the jigsaw and might have some clues within it as to how we tackle some of these challenges in the future. I should say as well, it's also interesting how the funding has worked, and that rather than it being a typical funding stream where they've put funding on top of existing funding, they've looked to the NHS have tried to look at opening the research into new populations that have had significant unmet need as well. So I think that's really important, and I'm delighted that the NHS have taken that step. So we used the Marmot work around social determinants of health, thinking about the causes of the causes. Public health is really fascinating in their approaches they do. They look at things like common origin approaches and how interventions can be really targeted upstream and tackle, risk factors that might focus on, multiple diseases, smoking being a classic one, physical activity is another great one. So these are some of the community assets that we're linked in with. Everton in the Community, Saints Community Foundation, and the populations that we've picked are where there is real need. So St Helens, Knowsley, Wigan, so really important areas in the northwest with some significant challenges. I'll put the Haydock Band up there. So my dad's been in the Haydock Band for 60 years now, and it's been going for 100 years, but I think it's a really nice example of a community asset that's deeply embedded in the community, has helped children and young people over many, many years. And yeah, it might not start out as being something scientific to explore. I think as a phenomenon and as a community asset, those sorts of community assets are really worth exploring. So I've done my alter ego was I've done quite a lot of Ironman racing in the past, so I was challenged to try and weave that into the talk somehow. So yeah, it did give me a lot of insight into physical activity and the importance of physical activity as a preventative phenomena. I'm certainly not suggesting that anyone needs to go and race an Ironman, but when I'm looking at the literature, even modest amounts of physical activity, walking, there's very good guidelines and around the amount of physical activity people should do. And there's the team in the Sports and Physical Activity Centre at Edge Hill really do some excellent work around that and how it can be promoted. So yeah, it gave me really good insights. It gave me good insights into strategizing, thinking about different disciplines and swimming, biking and running, and how different forms of knowledge are integrated together. So I ended up doing about 15 Ironmen in the end. But yeah, it was a great part of and a good stress reliever after doing PhDs and things like that. So think about models of care. So Joanne Reeve. So Joanne's been a really important person in my academic career throughout. When I was doing a PhD, she was a good mentor. She helped me with framing my doctoral fellowship. And she's also now one of the external advisors on EPIC and the Edgehill Primary and Integrated Care. I've done lots together, but Joanne's area of interest is generalist practice and medical generalism as a phenomena. So looking at the patient, taking very patient-centred approaches and dealing with multiple problems. And she argues very passionately for that patient-centred care through that generalist lens and how that has somewhat been eroded within healthcare at the moment. So Joanne argues that generalist practice is decision-making which is person, not disease-focused, which is continuous, not episodic, and integrates biographical and biotechnical knowledge. So it's integrating different forms of knowledge. So this is really the essence of what it is being a general practitioner. You know, you've got the patient's narrative and you've got those multiple guidelines that you've got to try and bring into and then frame it with shared decision-making for the patient. So we did lots of work together, and one was around generalist expertise. And we did this piece about what are the constraints to generalism, what stops it from being adopted. And one thing I was quite passionate about was time that you spend with the patient. And it's been something that has been something I've looked at in quite a lot of detail. This is a quote from a trainee. He said that time spent looking after complex patients is well spent. There's often no time for this in a busy day. And I think most GPs would agree with that in clinic. Opportunities for dealing with those multiple problems can be really challenging. One of the great experiences I've had is, and I've always been quite passionate about it, about international collaboration. And I've been privileged enough to have about 3 or 4 trips to Japan to look at how their healthcare system works. And I came away with an awful lot of that and some really important collaborations that exist to this day. And yes, that is one of the GP professors in the bottom right-hand corner, Professor Kasai, who hosted me when I first went. He worked in the community where the tsunami hit in Fukushima, and Professor Kasai is seen as a bit of a local hero. And this was a post that was put by some patients because he brought primary care, family medicine into that community that had been massively displaced because of the tsunami. And he talks very passionately about the importance of primary care, and he's very much an important mentor. I should say primary care has only existed in Japan for a relatively short period of time compared to the UK, so hence the need for that collaboration. I've had the chance to go out and do home visits, look at the introduction of primary care in isolated islands off Okinawa, looking at different parts of the country, and it's been really fascinating. But they serve a population that's a super ageing population. Life expectancy is far longer than here, and they do have quite a well-developed system for dealing with long-term conditions. So it's very fascinating to see that, and I think we have a lot to learn from other countries. So I think that's an important message from me today. So one of those collaborations that we had was looking at international variation in consultation length, and again framing that as a key enabler for supporting people with multiple long-term conditions. I won't go into too much detail, but you can see that there was a significant difference between the countries. Sweden, 20 plus minutes, and countries like China, Bangladesh, Pakistan, little more than a minute. So you have to ask yourself, is this the same intervention, the same thing that you're offering? Everyone's calling it the same thing, but there's a lot happening there. So when we published this, it got picked up by the media, went absolutely bonkers when we published it, and all the different countries were comparing and making comparisons as to how long they would have. I remember my mum calling me, Anne, at the front, when Lorraine and Dr. Hillary were discussing it, and it was on, I think it was Good Morning Britain and others, and they were talking about the news headlines that said that Britons were given less time with their GP in Peru. And Dr. Hillary was very articulate about it, and he was saying about the importance of time in any practice. So it was actually, although you always get anxious about how people interpret the findings, it's very interesting. BBC picked it up about short consultations, Der Spiegel, Le Monde, Times of India, they were all reporting, which was really interesting. And don't want to get political, but the different political parties in this country were making comparisons between England, Wales and others as well. So it was a really important hot potato. But the thing I was most pleased about was that the Lancet Global Commission on High Quality Healthcare Systems picked it up as well, and it became part of that. They took like a position statement to UNICEF and to the UN, and made a statement that nearly half the world's population were spending less than 5 minutes. And a number of countries then made a powerful statement saying that we would look to increase consultation lengths where possible. My argument was, what's the point of having access if the care that you receive once you get there is poor? So it's time and space for dealing with the problem is really important. And it made it into the technical series from the WHO on multimorbidity. I should say that's not been updated for quite a number of years now, which I'm really surprised about. So that's another key message today. In terms of guideline developers, I think NICE need to update, and I think WHO need to update theirs as well. The RCGP featured it in their compendium evidence. And I think this is really nice. So this is, Edgehill has recently received funding for a number of internships and intercalations for its MB-CHB students. So some of those students have been updating the review. So a few years on and looking at the difference to see what's happened within countries, looking at the literature. And pleased to say, a good number of countries have improved, somewhat. The UK is we've marginally improved. It's like, I think it's gone from like 10 to 10.1, so we're pretty static. A lot of countries have either reported for the first time or not moved. Some countries have gone backwards, and some of these are countries like Japan, Spain. So these are big economies. So there is some interesting phenomena going on there internationally, I think. But I'm really proud of the students that they've, that they can take part in this work as well. It was Eleni, who's in the picture there, was one of my students, and she got to present her work in Parliament recently as well, in the Posters in Parliament scheme. So I think that's a really nice impact that Edgehill students are having on health of this nation and others as well. Very quickly, looking at engaging with other organisations outside of health and social care, so the VCSFE groups. So we've got some funding for looking at how we can work better with those organisations as well. I think that's really important. And one of our new ACFs, Anna Zatorska, she's an academic clinical fellow, she is leading on some of that work. So again, another nice example of the schemes that Edgehill's put in place, tapping into the NIH Academy. I was very privileged to do that. And Anna and Sam, our two ACFs, have really done some sterling work in terms of leading on that. I've had the opportunity to look at developing the research and innovation strategy for Cheshire and Merseyside as well. And what we've tried to do, I think this is really important, is when any care pathways are developed, we've looked at including research and innovation in every care pathway that's developed, and that includes work on multiple long-term conditions. So when anyone writes a guideline now, they can't just go out and write it. They have to consider the body of evidence that's needed there. And I'm really pleased to see that involves working with a lot of partners and not just the same old groups that you might imagine. And in terms of priorities of research, you can see the condition themes. A lot of the big hitters that we've just mentioned in those long-term conditions are there, and how that impacts on complex lives and patient flow within the system, with prevention being a cross-cutting theme. So there's lots of opportunity. We've done some work with Lord Darcy's team as well about digital access and some of the challenges that can come up with that as well. So it's very topical at the moment with the NHS long-term plan about how that's developed. Finally, I'm just going to come to a little bit about infrastructure and research delivery. So all the design of research is really important, but another key piece of the jigsaw is how that's delivered. And I think the distribution of how research is delivered is also important as well, giving access to giving the population access and opportunity to take up and be part of research, should they so wish. So we've done a lot of work with the NHR RDN, who've been very supportive of that deep end group I presented early on. And yeah, if anyone wants to be part of a study who's listening, you can go onto the website there and you can see what studies are happening locally in your community, and you can take part in them. So a bit like everyone has universal access to healthcare, you should have universal access to research should you wish to take part as well. So yeah, we were really proud to open one of the first clinical research hubs as part of the NHR network. So I'm hoping some of our projects that we have here at Edgehill will go on the portfolio, and we'll develop a bit of an ecosystem where we can support the really good work that takes part here and give it to populations locally and nationally that would really benefit from that research. So last slide, yeah, as I say, it was just a reminder that as Hercules found out, the last head is really challenging, and it's the immortal head, and we mustn't overstep and think that we can overcome all the challenges of multiple long-term conditions. There is that element that of thinking about conditions where there's some elements are going to be naturally occurring, and we mustn't risk over-medicalising by trying to tackle things too far. And a key way to do that is that patient-centred care and offering good support, continuity of care, giving people time, and that's really, really important not to forget. Last slide, just want to say a huge thank you to my mum and dad, who are they've been there throughout the entire journey and been really supportive with everything I've done. Tina, Finn, Guy and Max, the team at home as well, who are incredibly supportive with everything I do. So really grateful for them for enabling me to do what I've done. Thank you very much.
Thanks, Greg. So I'm Jeremy. I am Associate Dean for Research and Innovation in the faculty. I feel privileged to work with Greg every day here at Edgehill when he's not in clinic. It's a privilege to work with you. I think that commitment to making a difference really comes through in everything, in everyday meetings and a lecture like this evening. It really does make a difference, and we're lucky to have you, and thanks. And I'm also quite excited at what's coming next. So just on behalf of everyone in the room and everyone online, I just want to thank you for this evening's lecture. We have got time for questions, so I'm conscious we've got people online.
Yep.
So Zara's got the roaming mic, so if we start off with questions in the room, and then maybe we can take a question from online, if that's okay. Any questions?
Thanks, Greg. That was fascinating. I've got about 150 questions, but I'll limit it to one. You alluded to technologies in various parts of your talk, and in the past 2 or 3 years there's been an explosion of biotechnology and information technology that's moving more into the AI space. What do you think the future holds, and how will it impact on the management of multiple long-term conditions for people themselves in terms of home management and research?
Yeah, that's a really good question that I often think about at night. In when you're kind of your mind's wondering, like, where's it? Where in 10 years' time, in 20 years' time, where's this going? On the one hand, it's an incredibly exciting time, in that the data flows that exist now never previously exist. I think one thing I would say about the St Helens community is it was very early to adopt a shared care record, link that social care. So it was very visionary, and that's become quite widespread now. And there's a shift towards the regional secure data environments, which are going to be like a national grid of data. That comes with challenges, but I think really good opportunities for looking at across different settings and looking at things in a different way. And methodologically, yeah, the AI sphere really excites me. I was over at Hydra. I've been over there 2 or 3 times now, looking at machine learning approaches and how they can, they've got really excellent computing power, but perhaps more importantly, really good expertise in terms of those machine learning approaches. So we're very fortunate on our, here at Edge Hill and within our region, there is some really world-class methodological expertise in computer science. I think we don't need to go crazy. I think it's important to pick the right tool for the right job. So you don't need to, you like for example, Hydra had quantum computers and they've got some really excellent infrastructure. But do you really need that level of computing to answer some of these questions? So I think, Gareth, you don't need to jump straight to doing something super complicated. The very nub of what I think about in your question is, it's one thing to describe clusters epidemiologically. That is very interesting to look at how the patterns sit. But it's that so what question. And for me, the so what question is, how are those clusters actionable? We co-designed the work we presented with local GPs, but I think there's a bigger piece of work to be done around how that becomes actionable then. And I don't know to what degree machine learning will overcome that. I think it'll offer huge opportunities in terms of tackling polypharmacy. I think there's some real quick wins there for identifying, why don't you stop this drug, and there's some really exciting work that's already happening in the region in relation to that, some really novel approaches. I'm very keen to look at the performance of the AI as well, compared to those conventional approaches as well. So I think that's a really important methodological step. Can it perform better? There's an assumption that it can, but I'd like to put it to the sword and test it and prove that it can describe things in a better way. From a wider general practice perspective, it's a really, wicked environment. It's very, very complicated, and that consultation is perhaps the most wicked part of the entire environment. There's some probably other quick wins in the other parts, like looking at lab results, looking at medications and things. That's where I would target efforts initially. All of that needs to be done in a very joined up way, otherwise you're going to have a myriad of tools that are not joined up as well. So for me, it doesn't get away from the fact that you need to have good inclusion from good patient and public involvement as well. So you shouldn't just throw all those things out just because of the technical appeal of approaches as well.
Thank you.
Thanks, Greg. That was a really, really brilliant inaugural. Thank you so much. I'm going to ask you the obvious question for me, which is around asset-based community working, and how can we better use data? And I'm thinking particularly because we've had a few conversations about Cypher in particular, and particularly that kind of mapping that areas of deprivation. But how can we use that to empower and enable our community-led response to prevention of multiple conditions? Yeah,
there's a lot of excellent work that goes on in communities, and I think quite often when we look at the data sets, some of that, even identifying where someone has received an intervention is often absent or inconsistently reported. So I think there's a big piece of work to be done, and maybe that might come out of some of the REM work and other work that goes on around how we can better capture some of that activity that goes on. Sometimes it's done by very large organisations, sometimes by small. One thing I didn't put into the talk, but I was thinking about is going back to basic principles of population health and prevention, and whether there's the Jeffrey Rose's paradox, which is around is it better to look at interventions that take a very universal blanket approach that engage big communities and might have a little effect, or whether to take a much more look at interventions that take a much more targeted approach and stratified, and Jeffrey Rose argues that sometimes taking that bigger population approach can lead to a better impact from a prevention point of view. I don't know if things have moved on from when that work was written, but I'd love to see how different community assets perform, like ones that are, that maybe like Everton in the community that really embraces a large population of children and young people versus ones that focus on those with high risk specific need as well. So I think there's some really interesting work to be done around the impact and outcomes that those different types of assets have as well.
So Greg, just on behalf of everyone in the room and everyone online, thanks for an amazing lecture this evening, and we can carry on the conversations at refreshments outside. Thank you.
Thanks.